Good morning, dear colleagues from Sri Lanka. I am very happy to be with you. And I must thank a lot the President of the College of Dermatologists to give me this opportunity. But I must tell you that I am not in the best situation, you know, because I had some problems with my flight schedule. I was due to be in Sri Lanka to give you this lecture, but I am in Malé, in Maldives Islands, and I am in the middle of the airport. So please don't have bad thoughts, you know, and bad ideas if you can hear some noise or something like this. But in the same way, we'll talk about our topic, you know, the new trends in the management of melasma and facial hyperpigmentation. And you'll see that my lecture is focused on tranexamic acid because I think that this is really the new trend, you know, and the big news in the treatment of melasma for many years. You know, we stood many years with hydroquinone, especially as a gold standard, and now I just consider myself that the gold standard is no more hydroquinone, but much better this tranexamic acid. I will share my screen now. Can you see it? Yes, and so tranexamic acid, you know, it's not anything new because it's an old molecule. It was discovered in 1962, a long time ago, and widely used in the treatment and prevention of hemorrhages. Tranexamic acid in medicine. And of course, for this use, we had two different galenic forms, you know. One was oral, like a tablet, and the other one was intravenous injection for emergency use. And chemically speaking, tranexamic acid is a synthetic derivative of amino acid lysine. And as you can see, it's a small molecule, you know, it's a small size molecule. And this is very important because this means that it can penetrate through the skin barrier. So, in dermatology, the first mention was in 1979, and the Mexican colleague Lopez Gonzalez tried using it in the oral form in actinic prurigo, and he got very good results. And much later, 20 years later, by the end of the 20th century, Japanese investigator Maeda was able to demonstrate in vitro that tranexamic acid was blocking melanogenesis. And this was really a new step in the life of this molecule. And after that, from 2010, more or less onward, we had a lot of publications, of papers, of trials using tranexamic acid, and especially in melasma. And first, you know, because there was no topical form of tranexamic acid, we were using oral tranexamic acid. And in this case, there is a consensus that the doses, daily doses is 500 milligrams, you know, 250 in the morning, 250 at night, and duration of treatments is 3 months. Knowing that after 1 month, we already have some result, which is improving after 2 months and so on. 3 months, you are able to in this lady, you have an optimal result in this patient from Nepal. And it's very interesting, and I think you will be interested by this, that most of papers, most of trials are made in Asian skin, you know, and many of them in Indian skins or skins very similar. This is first example. This is another Indian patient. You see that really the result is wonderful after 3 months. This is a Korean patient with fair skin, you know, and you see that irrespective of fair or darker the skin, we have good results with this protocol. This lady from Pakistan is also a fair skin patient, and she has very good result. But the problem, you know, is about systemic side effects of tranexamic acid. And there are not frequent systemic side effects. It's not very, very frequent, maybe one patient in 1,000. But the problem is that they are very severe side effects. We talk about pulmonary embolism, about deep vein thrombosis, myocardial or cerebrovascular infarction, renal necrosis. Really, we have to think twice, you know, before prescribing oral tranexamic acid in melasma, because we are treating cosmetic disease, you know, cosmetic disorder, and systemic side effects can be really very severe for our patient. And for this reason, in 2010-2012, we had the first tranexamic acid in melasma. And you see that about the time and the length, the duration of treatment, we are also talking about 3 months. And after 3 months, we have a complete healing of the lesions. There is no consensus, on the contrary, about the concentration of tranexamic acid in the cream, and we are ranging in terms of trials between 2 and 5%, mainly 2, 3, and 5%. And you see that with 3% tranexamic acid, we have also very good results. And I love this picture, you know, personally, because we are observing very well that melasma is not only pigmentation disease, you know, but also a vascular disease. And we'll talk again about this. And I think this is very important once we consider the management and treatment of tranexamic acid to take into account this vascular component. And then you see 3% tranexamic acid twice daily, 3 months with very good result. Another case with 3% with almost complete healing after 3 months. And now this is something important for me, you know. I will insist about combination treatments. I know that we dermatologists are very fond of office procedures and so on, because we know how to do it, we are skilled about it, and we are getting good results. But we can increase the results of these procedures by prescribing topical tranexamic acid to the patients and having a double treatment, you know, by one side office procedures and on the other side home treatment with topical cream, for instance. Sorry. And this was the case in this study, you know, where there was application of 4 sessions of intense pulse glide on one side and plus 2% tranexamic acid, and on the other side only IPL, and the result was better with the combination treatment. You can also not only combine tranexamic acid with procedure, but also combine with another active ingredient. And in this case, niacinamide, vitamin B3, is giving very good results. Now, back to melasma. You know that, and we all know that it's a common cause of facial hyperpigmentation, and a lot of patients are affected. Sun exposure, oral contraceptives, pregnancy may exacerbate melasma, but are not really the cause of melasma. And the treatment, as far as we didn't talk about tranexamic acid, was mainly depigmentation, and as a gold standard, of course, hydroquinone, which was much used, but also we were using chemical peelings and laser and energy devices. So this is excess, melanogenesis excess. Further to that, there was some problem at the level of various cells, either epidermal or dermal cells, you know, and almost all skin cells will be implied in the pathogenesis of melasma. And the first ones are mast cells. You know that mast cells are producing histamine. Is stimulating melanocyte, and fibroblast is also involved because in case of melasma, there is a higher secretion of stem cell factor, which is also positively impacting the melanogenesis in the melanocyte. In the same way, endothelial cells are producing higher quantities of endothelin 1 in case of melasma, and increasing production of melanin by the melanocyte, and the same for keratinocytes. So it's really a multifactorial condition, you know, and all skin cells are involved at a certain stage, you know, in pathogenesis of melasma. And how is tranexamic acid working in this case? It's working in two different ways, you know. The first one is a direct action on the melanocytes, and the other one is an action on the other skin cells. And you first we'll talk about the action on the melanocyte, and this is the classical mechanism of action of tranexamic acid in hemorrhages, you know, as anti-hemorrhagic. What happens? We are blocking the transformation of plasminogen activator to plasmin, and then the stimulation of alpha melanocyte stimulating hormone, of fibroblast growth factor, and of the production of arachidonic acid, and then impacting negatively on the melanocyte as per melanogenesis. But also there is a blockade here by tranexamic acid of the induction of vascular endothelial growth factor by plasminogen activator. So we have two different ways. The first one on melanogenesis, the second one on the vascular component. So, and about the other cells, you know, we are also working by reducing the levels of vascular endothelial growth factor. We are also reducing, as a consequence, the number, the size of endothelial cells, you know, and of small vessels. This is important. We are also impacting fibroblasts with tranexamic acid. We are impacting mast cells, you know, and permitting to reduce their release of histamine. And we are also working on keratinocyte. And all of this independently from the action we have directly on the melanocyte about melanogenesis. Now about its toxicity, tranexamic acid has really a very good toxicological profile, as you can see, in terms of acute toxicity, of repetitive toxicity. And look at this, very important, tranexamic acid is not teratogenic. And we know that very often melasma will happen during pregnancy, and we can treat our patients with melasma during pregnancy and also during breast suckling with tranexamic acid. This is very important. And now I told you from the beginning about the importance I find personally in combination treatments. And there were a lot of treatments as office procedure and combination treatments which were recently published. And quite frequent use of tranexamic acid is in association with microneedling, you know, with dermaroller or dermapen. And in this case, 0.5% tranexamic acid solution once per week, 12 weeks, and you can see the results. There are very good results. Here we have also the same kind of procedure, you know, with dermaroller and 10% tranexamic acid, 6 sessions every 2 weeks, always 3 months, you know. We must keep these 3 months in mind. And you see that, of course, the reduction of MASI score was much bigger with the combination of tranexamic acid and microneedling than with only microneedling. you see that the result is completely different, and we can get very good result with microneedling and tranexamic acid. Now there is another way, besides microneedling. This is intradermal injections of tranexamic acid. This is working very well on melasma. And in this case, there was a comparison between the oral treatment, with 500 milligrams per day versus 0.4% intradermal injections once per month. And you see that the result in terms of reduction of MASI was absolutely equivalent. So we can get the same result as oral treatment with office procedures. And you can see here some pictures extracted from this trial. You see that really the results are very good, even in case of severely affected patients. And you see here, this photo is very interesting because we see once more the impact of this vascular component of melasma. It's not only hyperpigmentation, there is also a strong vascular component, and for this reason, tranexamic acid is superior to any other treatment in the management of melasma. And you see that we had few comparative studies, for instance, intradermal 2% tranexamic acid versus topical hydroquinone 2% twice per day. And you see that the result was better with tranexamic acid than with hydroquinone. You have here a few examples. You see that with tranexamic acid, you can have at least results similar to hydroquinone 2% and even better. And now intradermal tranexamic acid 0.4% or 1%, one of both concentrations, versus hydroquinone 4%. And you see that if we talk about tranexamic acid 1% in intradermal injections, we have similar activity, similar depigmenting activity as hydroquinone 4%. And the difference, of course, no need to insist about it. The difference is about tolerance, and side effects. Because we didn't talk already about this, but tranexamic acid, as well as in a topical form as during procedures, has an excellent tolerance. You see here the both sides treated by tranexamic acid 1% or hydroquinone 4%, the results are positive and very similar. Now, intradermal tranexamic acid 10% plus hydroquinone 4% versus hydroquinone 4% alone, and you see that the combination has much better result than hydroquinone 4% alone. And once more, I will insist, for me, if we don't talk about procedure, we talk only about home treatment by the patient, daily use of topical tranexamic acid plus hydroquinone 4% at night is the best combination, because you are really impacting very strongly with tranexamic acid on the vascular component, and you have I think, the best anti-depigmenting agent, anti-melanogenesis agent with hydroquinone 4%. This is really an excellent combination. And you see that the results are very good, and you see that the result with combination of hydroquinone 4% and tranexamic acid is much better than hydroquinone alone, because we are working also on the vascular component. Topical tranexamic acid 5% versus topical hydroquinone 3%. You see that the results are similar, but the difference, as I told you, is about tolerance, because in case of hydroquinone, there is like 20% of side effects, irritation, erythema, pruritus, or something like this, and we don't have it with tranexamic acid. And you saw that the results are wonderful also. Now, oral tranexamic acid plus topical tranexamic acid 3% versus oral tranexamic acid plus 20% acelaic acid. You see that the combination with tranexamic acid is better, is giving better results than the combination with acelaic acid. Yeah, we already talked about it. And now, very interesting, you know, because all of us, we love using our and lasers and this kind of devices. You know, we are getting very good in melasma. And in this case, there was a trial of combining Q-switch laser with topical tranexamic acid 3%. And you see that the laser is giving a good result, but after 1 month, there is a tendency to recurrence of melasma. And with the combination of laser plus topical, a better result after 1 month, and tranexamic acid, there is an absence of recurrence of melasma. So we have a double advantage in combining both treatments. And you see the results. The big advantage is about avoiding recurrence of melasma. Well, I wanted to introduce this case, you know, but we must be careful. This case is use of tranexamic acid in oral form, oral treatment in post-inflammatory hyperpigmentation. And you see that the result was excellent. But my question, you know, my problem is that we don't talk about clinical study about a series of patients or something like this. We are only talking about one case, and this is the only case published to date, you know, with tranexamic acid and post-inflammatory hyperpigmentation. And according to my own experience, I tried it, of course, but I can tell you it's not working. And if you are with a patient with post-inflammatory hyperpigmentation, it's much better continuing prescribing hydroquinone than tranexamic acid. Because why? Because post-inflammatory hyperpigmentation is a pure pigmentary disease, you know, a pure disorder, and there is no vascular component. And in this case, tranexamic acid cannot help. So, of course, after receiving so many data and different data and concentrations and so on, we are a little dizzy. And this was my feeling, you know, 2 years ago. And I started published at that time in the 2000, what is the date? In 2019, it was in September 2019, I found almost 500 patients treated with intradermal injections of tranexamic acid, 1,100 patients with oral treatment, and 311 with topical treatment with tranexamic acid. And after analyzing these results, so you see the best way for using tranexamic acid in melasma are intradermal injections, 0.4% once per very good result, almost a 65% reduction of mass. The second best procedure is use of topical 3% tranexamic acid twice per day. You can reach 56% in the decrease of mass score. It's a little less with topical 2% tranexamic acid. It looks logical, you know, that 3% is stronger than 2%, but it's not logical that 3 and 2% are stronger than 5%. And we think nothing was absolutely proved, you know, but we think that in case of using 5%, we are using an excess of active ingredient and we are saturating some receptors. And the last one, it looks strange, is the oral treatment with daily 500 milligrams of tranexamic acid. It's giving only 39% reduction in mass score. In terms of safety, because we have to be very careful about safety, you see that with injectable tranexamic acid, there were very few side effects. Very few side effects, and when there was any side effect, like pain or pruritus at injection site, so nothing very serious. In case of topical tranexamic acid, no side effect except this study, but this study was in 2012, and there was no commercial product with topical tranexamic acid. So I am sure that the problem was with the excipient, you know, because it was a home-made formula, and the problem was excipient because no other study never reported side effects, you know. So topical tranexamic acid is very safe. And oral tranexamic acid, all of us, we know that sometimes there are some gastrointestinal side effects with tranexamic acid, not very severe, not very frequent. And once among more than 1,000 patients, you know, we had really a severe side effect with deep vein thrombosis requiring prompt discontinuation of treatment, of course, but also hospitalization of the patient. And now about procedures, you know, I didn't publish it, not yet, but I did the same kind of review, and this one is more updated. You know, it was mid 2021, and I was finding quite a lot of studies, and the result, you know, the best protocol with tranexamic acid and microneedling is with a concentration of 10% every 2 weeks and duration, as always, you know, 3 months. About intradermal injection, the same kind of analysis gave the result of best concentration is 0.4%, frequency every week, and still 3 months, you know, no change about this. And now, to finish this presentation, you know, we talked a lot about melasma, but we can also use tranexamic acid in rosacea, and we have very good results. That's why I wanted, it's a little out of the scope of the lecture, you know, because we talk about hyperpigmentation and melasma, but as we talked a lot about tranexamic acid, I had to present these results, and this is a very simple treatment using 10% solution on a gauze, soaking gauze, and applying on the lesions for 20 minutes once per week. You see that the results are excellent. And we can get the same result just with topical 3% tranexamic acid. And last publication, it's very interesting also. It's about erythema post-acne, and there was a publication of a study in United States, and you see that after 2 months of using topical tranexamic acid, there is a important reduction of erythema post-acne, and this can be, it has to be verified, and double-checked, but this could be a good opportunity for the treatment of this erythema. So I thank you very much, and I am very sorry about the bad conditions, and the noise and everything, but I hope you appreciated this event and this lecture. And what I suggest maybe is that Dr. Prabhat gets in touch with everybody and collects questions, and I will answer the questions personally to all of you, because it looks difficult to do it in such conditions, but I don't like, giving a lecture and don't answering questions. I think it's the best part of the event, and I don't want to miss it. And then we'll collect the list of attendees, and Dr. Prabhat will get in touch with all of them, and you'll be able to make questions. And as hopefully I will be in Sri Lanka tonight, I will be able to be very close to you and to answer your questions. So, my dear colleagues, thank you very much once again. And thank you to the President of the College of Dermatologists for inviting me and permitting me to give this lecture. Thank you and have a nice day.